Hello and welcome back to our video presentation of shock. In this section, we'll be discussing the causes of obstructive shock. We know the three causes of obstructive shock, which is cardiac tamponade, tension pneumothorax, and a massive pulmonary embolism. Now let's understand the pathophysiology of each one of these. Beginning with cardiac tamponade, we know that the heart is situated inside the pericardial sac between the two lungs. Now within the pericardial sac, there is pericardial fluid. The amount of this fluid can increase if there is trauma and blood starts to escape into the pericardial sac, or it can be in terminally ill patients with cancer or tuberculosis or any other autoimmune diseases. So when there is increase in fluid around the heart, the fluid has no other way to escape other than causing back pressure onto the walls of the heart. This back pressure hampers the heart from filling adequately and thus decreasing the cardiac output and leading to shock. This is known as cardiac tamponade. We identify cardiac tamponade by the help of Beck's triad. In Beck's triad, the first thing will be muffled heart sound. So when you place your stethoscope over the heart field to listen to the heart sounds, if there's no normal contraction and relaxation, it's not going to generate the heart sounds. So you're going to have muffled heart sounds. There's going to be increased intrathoracic pressure. The blood is not going to be able to come into the heart for filling, which is why you're going to get JVD. You're going to have jugular vein distension. And then you're going to have narrowing of pulse pressure. So how is pulse pressure generated? Pulse pressure is generated by the difference between the systolic blood pressure and the diastolic blood pressure. Systolic blood pressure happens when the heart ventricles contract, and when they relax you get a diastolic blood pressure. But in case of cardiac tamponade, both these things are hampering. The heart barely has a chance to relax and it barely is able to contract, which is why there is hardly any difference between the systolic and the diastolic blood pressure, causing a narrowing of the pulse pressure. So cardiac output decreases, leading to shock, and Beck's triad of muffled heart sounds, JVD, narrowing pulse pressure together will help us identify cardiac tamponade on the field. Now talking about tension pneumothorax. What happens in tension pneumothorax? In tension pneumothorax, normal air which is inside the lung tissue starts to escape out into the chest cavity. And the air only travels in one direction. The air never comes back into the chest tissue. So more and more air starts to collect. More and more air starts to collect into the cavity, which starts to cause a pressure onto the side of the tension pneumothorax. So say you have a tension pneumothorax on the right side, the right lung starts to collapse, pushing the mediastinum onto the left side. All the structures within the mediastinum start to go onto the opposite side, which means that the heart starts to get pushed, the left lung starts to get pushed, and the trachea starts to push to the opposite side onto the left side. This is a picture of a tension pneumothorax. If tension pneumothorax is not identified promptly and rapidly treated by decompression, it can be very quickly fatal. The only treatment for this is to decompress, which is beyond the scope of an EMT, for which we need to have ALS assistance as soon as possible. How do we identify tension pneumothorax on the field? If the right lung is going to get collapsed, are we going to be able to listen to lung sounds on this side? No, we're going to have absent lung sounds onto the side of the tension pneumothorax. We are going to have increased intrathoracic pressure, which is going to cause jugular venous distension, and also we are going to have a tracheal shift. So when you try to figure the trachea, whether it is in the midline or not, by placing your middle finger, your index and the ring finger on the two collars of the on the two corners of the collarbone, and you find that the trachea is not in the midline but it's in the opposite side, it's because the opposite side has a tension pneumothorax. So if I have a left shift of a trachea, that means I'm having a right-sided tension pneumothorax. Tracheal deviation is generally a very last sign. So if you have a if you have a tracheal shift and you do not decompress, this case is going to be a fatal case. Talking about massive pulmonary embolism. Now, pulmonary embolism means embolus, a clot, which has gone and clogged itself into one of the pulmonary arteries. The pulmonary artery is the vessel that carries blood from the right ventricle into the lungs so that it gets oxygenated and it is brought back by the pulmonary veins to the left side of the heart. Now, if there's a clot onto the pulmonary artery which is still going inside the lung, it's not able to exchange oxygen, CO2, and the blood is not going to flow distal to the clot, which means it's going to start to put back pressure onto the pulmonary artery. The back pressure from the pulmonary arteries goes into the right ventricle, goes into the right atrium, and thus again it's going to decrease the cardiac output because there's going to be decreased venous return to the heart. So these are the three causes of obstructive shock. We've spoken about cardiac tamponade, pulmonary embolism, tension pneumothorax. In the next section, we'll be talking about cardiogenic shock and distributive shock. Thank you.